Hi everyone, and in this video I'll be discussing a topic called anticoagulants. And the previous video we had discussed a topic called antiplatelet drugs which prevent a clot in the arteries. Now let us discuss the drugs, that is anticoagulants. So what is the other name for anticoagulants? Anticoagulants are also called as antithrombotics. Since they prevent the formation of thrombus, they are called antithrombotics. Now you know that there is a virtuous triad. Virtuous triad consists of three things, that is stasis of the blood, hypercoagulability and endothelial injury. So any of these factors are there is a chance of clot formation, what we call it as thrombus formation. Now what are the cases where the thrombus formation increase in the vein? So there is increased thrombus formation can occur where? What are the factors where thrombosis increases? So when the patient can get thrombosis, when the patients are undergoing procedures. Because when you do a procedure, for example, when you are passing a catheter in the artery, you are injuring the endothelium. So procedures such as percutaneous coronary intervention, or when you are doing a surgery called cardiac bypass surgeries. So these procedures can generate a thrombus. Second important is when the patient is prolonged immobilization. So patient is immobilized. So usually the patients who are undergoing prolonged immobilization are the patient who have undergone hip surgery. Second, certain conditions called the hypercoagulable state, that is disseminated intravascular coagulation. Another important condition is called HIT, heparin-induced thrombocytopenia. Also, we have the risk of thrombus formation. And certain times cancer can also induce thrombosis. So there is something called cancer-induced thrombosis. And apart from that, there is a condition called atrial fibrillation. Atrial fibrillation. Now, when the atria fibrillates, what happens? It's not effectively throwing the blood into the ventricle. So there is a stasis of blood in the atria. I told you virtuous triad. Stasis can generate a clot. So the clot can form. It can get dislodged from the heart to the brain, and there is a stroke chances. So there I have to give a prophylaxis. And also when the patient is having prosthetic heart valves. When the patient is on prosthetic or mechanical heart valves, so there also the risk of thrombosis increases. So in all these conditions, we are going to use the anticoagulants or antithrombotic agents. Now, moving on to the important aspect. The important aspect I just want to add up is prolonged immobilization. Even during MI, there is a risk of thrombus formation. Then also we use this anticoagulant, particularly heparin and low molecular weight heparin. Now, moving on to the mechanism, how do I prevent a clot formation? So I should understand the thrombus formation. There are two pathways, extrinsic pathway and one more is called intrinsic pathway. So let me start with the intrinsic pathway. You know that it starts with the factor 12 getting activated to 12A. From that we get the factor 11 getting activated to 11A. From there we have the factor 9 getting activated to 9A. Now this will activate the factor 10 into 10A. And the 10A will activate the factor 2. Factor 2 is called as prothrombin, and that will give rise to 2A, that is called, the activated form is called thrombin. Now the thrombin which has formed will activate a factor called 1 to 1A, that is fibrinogen to fibrin, and there is a formation of clot and the clot will get stabilized. So this is what happens and the clot is formed. Now another important pathway what we need to understand is the extrinsic pathway. So we have the factor 7. Factor 7 will get activated to 7A, and this will also help in the formation of clot. So this is the extrinsic pathway and this is the intrinsic pathway. So we have two pathways here, intrinsic and extrinsic pathway, that is being dealt in physiology also. So how do I stop a clot? How do I stop this clotting mechanism? So this can be stopped. Let us discuss how do we do that. Before I come to this, do we have anything, endogenously present in our body which can prevent this clot? Yes, we have certain factors which can prevent a clot, or they are called anti-clots mechanism, that is the protein C and we have protein S. They prevent a clot formation. We have another factor called antithrombin 3. So antithrombin 3 is one more mechanism which can prevent a clot. But when we have this already in our body, then why should we use a drug? When we already have this in our body to prevent a clot, then why should we use it? The only reason is these will not act faster. So I need to activate them. So first and foremost, I can activate antithrombin 3. And that is activated by unfractioned heparin and low molecular weight heparin. So this will activate antithrombin 3 and that will inhibit the factors 10A and factor 2A mainly. So that is our first target. So the heparin group of drugs, they don't act directly. Please keep this in your mind. They don't act directly. They activate antithrombin 3 and that will inhibit the factors. So they are indirectly acting. That is target number 1. Now there are clotting factors 2, 7, 9, 10. These clotting factors are activated by the vitamin K. So vitamin K is required for activation of 2, 7, 9, 10. Not only for that, it is also required to activation of protein C and protein S. So now if I want to decrease this 2, 7, 9, 10, what should I do? I should antagonize the vitamin K, and that is done by vitamin K antagonist. The name is called warfarin. So the second target what we have in anticoagulant is warfarin. Remember this heparin which came in the beginning, they are all injections. But later what we came with warfarin, that is an oral drug. So these are the older drugs what we have, heparin and warfarin. Then recently the scientists started thinking differently. Then they started discovering a drug which can inhibit thrombin directly. So they are called as the third target, they are called as direct thrombin inhibitors. So DTA stands for direct thrombin inhibitors. Then later they found out to inhibit directly 10A, so they are called as 10A inhibitors. So they are direct 10A inhibitors. So we have the fourth target. There are basically 4 different group of drugs for anticoagulation. Number 1, we have the heparin group. Number 2, warfarin. And number 3, direct thrombin inhibitor. And number 4, the direct 10 inhibitors. So these are the anticoagulants what we have. Now we'll take up one by one and discuss their mechanism, uses and adverse effects separately. Okay, shall we start our journey? Yes. So the first target is the heparin group of drugs. Now I can call them as activators of antithrombin 3. These drugs, they don't act directly, they are activators of antithrombin 3. Activators of antithrombin 3. So what is the role of antithrombin 3? So I'll write it as AT3, that is antithrombin 3. See, this can inhibit so many factors. It will inhibit the factor 2A, that is the main action of this drug, antithrombin, which is there already in our body. Not only that, it can inhibit the other factors like 12A, 11A, 9A and 10A. So it can inhibit all this, but that's the major minor action. So whatever the heparin and we are using, they will activate this antithrombin 3. So let us analyze how these drugs are going to work. So let me write the drug. So the drugs are called as unfractioned heparin. It is called as unfractioned heparin. So I will be writing it as UFH in the future. Then we have low molecular weight heparin. So we have that low molecular weight heparin. And I will be writing it as LMWH in the future. And similar to that, we have a drug called fondaparinux. So these are the drugs what we have in heparin group, and all of them have the same mechanism. They activate antithrombin 3. Now if I go in detail and explain their mechanism of action, let me tell you. Now, what about unfractioned heparin? What is the mechanism of action? What about low molecular weight heparin? And what about the fondaparinux? What is their mechanism of action in detail? Now, the heparin has a pentasaccharide unit. This is the pentasaccharide unit. This is the one which is present with this. Now, along with this pentasaccharide unit, it has one more additional unit. This is the chain which is attached to this. Now, this, when the heparin comes in the body and starts working, so it will attach antithrombin 3. So, this is the antithrombin 3 which comes and sits. Now, this antithrombin 3 gets activated and it can inhibit the factor 10A. So, it can inhibit factor 10A, but to inhibit the factor 2A, it requires the side chain. So, the side chain is the one which inhibits factor 2A. Imagine that unfractioned heparin is like our body. This is the pentasaccharide, that is the middle part, and another is the chain, what I have written. Now, here the antithrombin 3 sits, and when it sits on that, it can also block 10A. To block 2A, it requires this additional chain. So, the unfractioned heparin has bigger size and large molecular weight, so it can inhibit both the factor, that is 10A as well as 2A. So, unfractioned heparin, if they ask in the exam what is the mechanism of action, it binds to antithrombin 3 and then inhibits the factors 10A and 2A equally. So, this is the mechanism. What about the story of low molecular weight heparin? Now, low molecular weight heparin, what they did is they have made the chain shorter. So, let me write that. So, this is the pentasaccharide unit, same thing present in low molecular weight heparin. This is the one. So, this chain has been cut short. So, that's why the weight has reduced. That's why it is called low molecular weight heparin. It will also bind the antithrombin 3 like this. So, by binding antithrombin 3, it will inhibit the factor 10A. It will inhibit factor 10A, but because the 2A is not able to bind properly, it will not inhibit 2A properly. It's like I can only bind antithrombin 3, I can block factor 10A. But to block 2A, this is not so much big, so I have been cut here. So I can only hold it mildly. So if they ask you what is the mechanism of action of low molecular weight heparin, please write like this: it binds to antithrombin 3 and inhibits the factor 10A more than 2A. So this is the mechanism. Fondaparinux is nothing but it's a synthetic heparin. So it is only having the pentasaccharide unit. It doesn't have that side chain. So it will provide attachment to antithrombin 3 and it can only block factor 10A. So it cannot bind 2A. That's why the mechanism of action is it binds to antithrombin 3 and inhibits 10A only. So this is the difference between the mechanism of action of different heparin group: unfractioned, low molecular weight, and fondaparinux, that is called synthetic. Since the chain is very long, the unfractioned heparin can inhibit both 10A and 2A equally. The chain is very short in low molecular weight heparin, so it can inhibit 2A but not completely. Fondaparinux doesn't have that side chain, it has been cut, so it can only inhibit 10. So this is the in-depth mechanism of action of these drugs. So I'll be discussing the first one, that is unfractioned heparin. So unfractioned heparin is one of the beautiful drug to correlate general pharmacology with systemic one. So the name itself is telling you it's big in size, unfractioned heparin. So it's large size. The drug is large size and the drug is ionized. So what should I take the message from this? If a drug is large size ionized, number one, it is not absorbed orally, so it cannot be given oral. So the drug is not given oral because it's not absorbed. Second, it is having large size and it's ionized. Do you think it will go out? It will stay in the blood vessel, so it will have low volume of distribution. Now, can we give it in pregnancy? Yes, the drug is safe in pregnancy. The drug is safe in pregnancy. The reason is it is not going to go out. Now, how do I give the drug? I can give the drug in two ways. Either I can give it intravenous. So intravenous, the advantage is the drug has fast onset of action. So it will start working immediately, fast onset. So, and it is shorter acting. So the drug is fast onset and shorter acting. So if you are doing a cardiac surgery, if there is a DAC, so if you want that drug to work faster and terminate the action faster, then we can use unfractionated heparin. Now the drug is metabolized by an enzyme called heparinase that is present in the liver, and it is one of the drug which is safe to be used in pregnancy. Safe in renal failure. Heparin is a drug which is safe in renal failure. The reason why it is safer compared to other anticoagulants, it has fast onset and it will get terminated faster. So that's why there is no need to worry for that. And can we use this drug subcutaneously? Subcutaneously, the drug is having different bioavailability. For example, some patient will have 20% bioavailability, some patient will have 70% bioavailability. So the bioavailability of the drug when we give subcutaneous is unpredictable. So because of unpredictability, subcutaneous if you give it, it may cause toxicity also, or it may not work also. So pharmacokinetically, these are the things you need to keep in your mind. The drug is large in size, it is highly ionized, so it is not given oral. It has low volume of distribution, it will not go out of the blood vessel. So it is safer in pregnancy, metabolized by heparinase in the liver. Can we give it in renal failure? Yes. The reason is simple. Because it is shorter acting, the action gets terminated easily. Second, it has abnormal bioavailability. Some people will have high, some people is low. So subcutaneous bioavailability is variable. So I can write it as variable bioavailability when we give it by subcutaneous route. So moving on to the important aspect, what is the adverse effect of this drug heparin? Obviously, when we give heparin or any anticoagulant, the risk is bleeding. So how do we monitor this bleeding? So if the risk is bleeding, how do I monitor? We require a lab monitoring. So lab monitoring, what we do for this is mainly APTT. The main parameter what we do is APTT. You can also do PT. If both are given an option, please choose APTT. That is the one which is usually done. Second, if there is a bleeding and toxicity of heparin, do we have an antidote? Yes. The antidote for heparin overdose, we have a drug called protamine sulfate. The name is protamine sulfate, and protamine sulfate is obtained from the fish sperm. But when we give protamine sulfate 1 milligram, that will neutralize 100 units of heparin, that is unfractionated heparin. So 1 milligram of protamine sulfate can neutralize around 100 units of unfractionated heparin. Now, general pharma, I will just ask a question. What is the antagonism between unfractionated heparin and protamine sulfate called? It is called as chemical antagonism. So the antagonism between heparin and protamine sulfate is chemical antagonism. Can you tell me why? Because heparin is one of the strongest acid and protamine sulfate is basic. So acid combining with base will neutralize it. So that's why it is called as chemical antagonism. So the first problem what we face with heparin is the risk of bleeding. The second important aspect what we can see with that is hypersensitivity reactions. Then patient may have alopecia. It is a long-term problem. Then mild increase in potassium, that is mild hyperkalemia. And one more important problem that happens is osteoporosis. So osteoporosis is a long-term complication. So number one, bleeding, obviously, hypersensitivity reaction, alopecia, mild hyperkalemia, and osteoporosis. One more adverse effect which is commonly asked in exam is the drug can produce a condition called heparin induced thrombocytopenia. So it is called as heparin induced thrombocytopenia. Sir, what do you mean by that? What is the problem here? I'll explain what is the problem here. The problem here is whenever we use unfractioned heparin or low molecular weight heparin, so there is something called platelet factor 4. So there is something called platelet factor 4. Now these two will combine and activate a immunoglobulin called IgE. So it is called IgG. So the IgG will activate platelet, so there will be platelet activation. So obviously when the platelet gets activated, we know that there is a formation of clot, that is thrombus formation. Now when the clot is formed, the patient may have myocardial infarction, patient may have stroke, or patient may have peripheral vascular disease, that is limb ischemia. So patient may have this problem. So clot formation. So later the platelets are consumed and the patient will end up with thrombocytopenia. So when you see this problem, do you think the problem is with the thrombocytopenia or clot? The problem is with the clot. So what we need to do is, suppose a patient is suspected with heparin-induced thrombocytopenia, you need to prevent the clot. So to prevent the clot, we use drugs such as argatroban. So argatroban is the drug of choice for heparin-induced thrombocytopenia. Apart from that, we can also use bivalirudin. You can also use a drug by the name fondaparinux. So they will prevent the clot, but the drug of choice is argatroban. So this is how we manage heparin-induced thrombocytopenia. So guys, I will give a simple clue to identify the adverse effect of heparin. I will give a mnemonic about. So remember it as about. A for alopecia and allergy. Second, B for bleeding. O for osteoporosis. Now U, what happens is aldosterone is undersecreted, so it will cause undersecretion of aldosterone. So what happens if aldosterone levels are less? What happens? Potassium, there is increase in potassium levels, so mild hyperkalemia is seen. That is the mechanism for that. T for thrombocytopenia. What do you call it as? HIT, heparin-induced thrombocytopenia. So the mnemonic is about alopecia, allergy, bleeding, osteoporosis, undersecretion of aldosterone leading to hyperkalemia and thrombocytopenia. Remember, this drug heparin, that is unfractioned heparin, is mainly used in emergency conditions like DVT, then pulmonary embolism. It is also used during percutaneous coronary intervention and cardiac surgeries. And one more complication where it is used is DIC, that is disseminated intravascular coagulation. Now, what was the drawback with this unfractioned heparin? The drawback is when you cannot give it subcutaneously because the availability is different. Second, the drug requires lab monitoring. And number 3, the adverse effects, that is osteoporosis, heparin-induced thrombocytopenia. So we came up with another group of drugs. They are called as low molecular weight heparin. What is the name of low molecular weight heparin? The name of low molecular weight heparins are enoxaparin. Please remember, they all end with parin. They are derived from heparin, so parin. Then we have dalteparin, then nardoparin, then we have tinzaparin. So if you identify parin in the name, that is obviously low molecular weight heparin. Now what is the advantage of this over low molecular weight heparin? Advantage of low molecular weight heparin over unfractionated heparin. Why this is preferred? Why this is preferred? Number one, low molecular heparin when we give subcutaneously, the bioavailability is very good. Bioavailability is good. Second, you don't require lab monitoring. No lab monitoring is required. Suppose if you start unfractionated heparin, the problem is you have to do lab monitoring repeatedly. It's a burden on the physician, it's a burden on the patient for the cost. Now, why we require lab monitoring there? Because the bioavailability is different. Some people it will be more, some people it is less. So you cannot predict. For example, if I give this much dose, I will see the therapy. If I increase the dose, I will see bleeding. So you cannot predict it there. But here, low molecular weight heparin, the prediction is there. If I give this much dose, the drug will work. If I increase the dose, the drug will produce adverse effect. So it has predictable anticoagulant profile. Because of that, there is no need of lab monitoring. Suppose if you want to do, you can do anti-factor 10 assay, but that is not required. You can do anti-factor 10 assay, but that is not required. Another important aspect is it produces less chances of hit and less chance of osteoporosis compared to unfractionated heparin. That is the reason if you observe in COVID-19, we all used in the hospitals low molecular heparin. The advantages are bioavailability is good. Because of that also the drug is also longer acting. Now you compare the unfractionated heparin, it is very short acting. And no lab monitoring is required and less chance of hit and osteoporosis. Remember, low molecular weight heparin, it's a drug of choice for cancer-induced thrombosis. So for cancer-induced thrombosis, if they ask in the exam what is the drug of choice, they are called low molecular weight heparin. Right. One more drug in this is fondaparinux. You read the name again, you will understand what is the importance of that. Parin, because it is derived from heparin. Ux, the last one, is going to tell you that it is only inhibiting 10A only. Fondaparinux, it also requires no lab monitoring. It doesn't require lab monitoring. What about any antidote? It doesn't have no antidote. It doesn't have antidote. You may ask a question, sir, what about low molecular weight heparin? If there is toxicity or overdose, do we have an antidote? Yes. For low molecular weight heparin, we have an antidote. The name is same thing, that is protamine sulfate. So the name is protamine sulfate. You can ask you the question, where do you use fondaparinux? It is used for heparin-induced thrombocytopenia. It is used, and it is also used in venous thromboembolism. HIT means heparin-induced thrombocytopenia, as well as it is used in venous thromboembolism. The name is fondaparinux. So recently there is one more drug that is called idraparinux. So whatever they give in the exam, if you know how to identify the drug parinux, it is a synthetic heparin. And what is the mechanism of action? It binds to antithrombin 3 and inhibits factor 10A only. Okay, so these are all injections: unfractionated heparin, low molecular heparin, and fondaparinux. And let me summarize the things. The antidote for unfractionated heparin, low molecular heparin is protamine sulfate. Fondaparinux doesn't have it. Lab monitoring is required only for unfractionated heparin. Low molecular weight heparin, fondaparinux doesn't require lab monitoring. So this is the aspect. Okay, the second anticoagulant group what we are going to discuss, they are called vitamin K antagonist. So they are called as vitamin K antagonist. And you know the drug name, and it is warfarin. The name is warfarin. Then we have dicumarol, then acinocumarol. So basically remember the drug warfarin. Now how do they work and what is the mechanism of action of warfarin? Let us analyze that. What is the mechanism of action of warfarin? How does it block the vitamin K action? We all know that the factors 2, 7, 9, 10, not only that, the protein C and protein S, they need to be activated. So they require activation. Now this activation is done by vitamin K. So let me draw like this. So this is the vitamin K and we call it as vitamin K reduced. So when the vitamin K reduced is required to make them active, after they make it active, vitamin K becomes oxidized. O stands for oxidized. So again the vitamin K should become reduced to again activate the further factors. So the enzyme which is responsible for reducing it is called vitamin K epoxide reductase. So it is called as vitamin K epoxide reductase. This is the enzyme which is vital to convert the oxidized into reduced form. So the drug warfarin is going to inhibit this. So warfarin is an inhibitor of this enzyme. So when we use warfarin, it inhibits the enzyme. So what happens? The clotting factors 2, 7, 9, 10, protein CS, they will not become active. Now this will not happen in hours. It takes days together. That's why a warfarin is slower acting. The drugs takes time to work because each clotting factor has different half-life. 2, 7, 9, 10, they have different half-life. So the drugs start working after 2 or 3 days. So the mechanism of action is it inhibits what we call it as vitamin K epoxide reductase. Now the question asked in exam is, you know that this is an enzyme. Is this inhibition by warfarin competitive or non-competitive? Tell me that. So the enzyme inhibition is competitive. So that means you can overcome this antagonism by increasing the vitamin K. So if we increase vitamin K, warfarin can be thrown out. So warfarin toxicity, the antidote is vitamin K. Now moving on to the pharmacokinetics, what are the important thing I need to understand? Warfarin, usually it's an oral drug. I told you after heparin, we got the oral drug that is warfarin. And is it absorbed very good? Yes, it has a very good absorption. It has a very good absorption. And warfarin metabolism is special. Warfarin has 2 types of isomers, the R warfarin and S warfarin. The R warfarin is the most potent. It is 4 to 5 times potent than the R warfarin. So the R warfarin is metabolized by the enzyme cytochrome 3A4, and you know that that is the most common drug metabolizing enzyme. The S warfarin is metabolized by cytochrome 2C9. So it is metabolized by the cytochrome, that is cytochrome 2C9. So the absorption is good and it's an oral drug. Another important is the drug follows saturation kinetics. And you remember the mnemonic watt power. So watt, in that we have warfarin. And it has slow onset of action. Slow onset of action. And it has more drug interaction because it is metabolized by cytochrome. It has more drug interactions. More drug interactions. It has more drug interaction, and the half-life of the drug is around 40 hours. It is around 40 hours. So is it safe in renal failure? Yes, this question is not asked till now. It is safe in RF, renal failure. So that is about the pharmacokinetics of warfarin. Very, very important. One of the oldest drug, but still it is used. Now what is the adverse effect of warfarin? Let us analyze. The adverse effect of warfarin obviously is bleeding. So patient will come with bleeding episodes. Now when the warfarin induces bleeding, there are 2 ways. One is, how do you monitor warfarin? Whenever we give warfarin, we need to monitor by something called INR. So INR stands for International Normalized Ratio, and it is nothing but prothrombin time, and the normal should be maintained between 2 to 3. That is a normal one. Suppose the patient is on prosthetic heart valves. Patient is on prosthetic heart valve. Then you can maintain it between 2.5 to 3.5. So to avoid bleeding, we need to monitor the lab parameter, that is INR. Suppose the patient has the risk of bleeding and we have an antidote. The antidote name is vitamin K. The antidote name is vitamin K. But the problem is vitamin K will not work immediately. It also takes time because it has to go activate the factors 2, 7, 9, 10, which takes time. Even though antidote is vitamin K, suppose the patient comes bleeding. If they ask in the exam what is the next step, so warfarin induced bleeding. If they ask you what is your next step, if the patient comes with bleeding, then what we have to do is we have a factor called 4-factor prothrombin complex. So we have 4-factor prothrombin complex that can be given to the patient because this is the one which contains the factors 2, 7, 9, 10, which is already activated. Not only that, it also consists of anticlots, that is protein C and protein S. So that can be given. Suppose the patient doesn't have that and it's not available, you can give fresh frozen plasma or you can do blood transfusion. But the best one is the first one, that is fresh, that is 4-factor prothrombin complex. So this is what we do. So please read the question carefully. If the question asks what is the antidote for warfarin, obviously the answer will be vitamin K. In the question, if they ask you warfarin is given, patient is presenting with bleeding, what is your next step? Then you have to give 4-factor prothrombin complex. What is the lab parameter I need to monitor is INR, the normal is 2 to 3. In case of prosthetic heart valves, you can maintain it between 2.5 to 3.5. Because prosthetic heart valve, it's always a risky and we need to monitor the chances of clot formation. So even if the dose is higher, no problem, but the clot should not get formed. So that's why we keep the higher level there. So number one problem with the warfarin is bleeding episode. What is the second problem? The second problem with the drug is it can cause something called purple toe syndrome. Now, purple toe syndrome is not a common problem. It's one of the rare problems. The reason for that is due to mobilization of cholesterol emboli. It is due to mobilization of cholesterol emboli that is called purple toe syndrome. One more problem that happens when we use this heparin is it can cause skin necrosis. Skin necrosis is also called as dermal necrosis. Now, what happens when we start warfarin? So this problem occurs when we start warfarin to the patient. What happens there? When you start warfarin to a patient, there are clotting factors. Now they have different half-lives. I will arrange them depending on the half-life. The shortest one with 7. Then we have the protein C. Then we have the factor 9. Then protein S. Then factor 10. And then factor 2. So this is the arrangement. For example, if I take this one, the half-life of this is the clotting factor 7 is 6 hours, and for factor 2 it's around 60 hours. So if I start warfarin, the first to disappear is 7, then protein S, then 9, then protein S, and what is remaining is 10 and 2. So the only opposition for clot formation in our body, I told you, is from protein C and S, and they have disappeared. Then who is remaining? The factor 10 and 2 are remaining, and they will form a clot. And that clot is responsible for the skin necrosis, or what we call it as dermal necrosis. How do I prevent it? So that's why whenever you start warfarin, you have to add unfractioned heparin or low molecular weight heparin. So whenever you start warfarin, you have to add unfractionated heparin or low molecular weight heparin. What happens? They have fast onset of action. They inhibit the factors 10 and 2, and there is no reason to form a clot. So what we do is we start warfarin and we continue them for 5 days. We gave them for 5 days and then stop. So we stop this drug after 5 days and continue warfarin later. So this method is called heparin bridging. So it is called as heparin bridging. So this will help us to prevent a complication of warfarin, that is dermal necrosis, also called as skin necrosis. So this happens when we start warfarin in the beginning. Now moving on to another complication which is asked in your exam is warfarin, is it safe in pregnancy? No. It is one of the teratogenic drug. The drug is teratogenic. Why? Because it's a blocker of vitamin K. It inhibits vitamin K. Thereby, it inhibits a bone protein called osteocalcinin. So osteocalcinin is blocked. So that's why the baby will have bony abnormality. So what is the teratogenic called as? It is called as fetal warfarin syndrome. It is also called by other name Contradi syndrome. Contradi syndrome. Any other name for that? Yes. It is also called as chondrodysplasia punctata. So all are the same name for this. So what are the features in this? The features is there is nasal bone hypoplasia. So there is nasal bone hypoplasia. Not only that, the patient will have stippled epiphysis. Stippled epiphysis. So there will be bony abnormalities. Please remember that. That is what we see with warfarin. Please remember these are the problems what we face with warfarin. Number 1, bleeding. Number 2, purple toe syndrome. Number 3, the skin necrosis. Number 4, teratogenic effect. Particularly that is most problematic in first trimester. Now moving on to the uses. It's an oral drug, right? So where do you use this? We use it in venous thromboembolism. So we have two conditions here, that is the deep vein thrombosis and pulmonary embolism. So we use it for prophylaxis. We cannot use it immediately. It's a drug for prophylaxis, number 1. Number 2, they are also used in atrial fibrillation. So atrial fibrillation is one of the beautiful drug. And number 3, it is used for prosthetic heart valves. And I told you prosthetic heart valves can generate clot anytime. That's the reason. So these are the major uses of warfarin. Moving on to the next, the third target. The third target in anticoagulants, they are called as the direct thrombin inhibitors. So the name direct thrombin inhibitors, that means they inhibit the thrombin directly. If you compare the heparin, heparin will activate antithrombin 3 and that will inhibit thrombin. So here the drugs directly do that. So we can give the drugs in 2 ways. One is as an injection, they are called parenteral drugs, or we can give them orally. So first of all, I will discuss the drug which is given parenteral. So we call them as parenteral direct thrombin inhibitors. Now in that, 2 important category of drugs. Now the drug which binds to both substrate plus catalytic site of thrombin, they are different, and the drug which binds only to the catalytic site of factor 2A, catalytic site of that is thrombin, that is 2A. Now what are the drugs which can bind to both? And you all know leech. Have you seen the leech? When you go to the forest, the leech will bite you and the blood oozes out. So from the leech, what we obtained is a drug by the name Hirudin. So similar to Hirudin, then we came with a drug called Lepirudin. So all these drugs, they end with rudin in their name. So Lepirudin, Hirudin, and one more drug is called Vivalirudin. And just now I told you Vivalirudin is used in the management of heparin-induced thrombocytopenia. And also it is used in a procedure called percutaneous coronary intervention. Then we have a drug called Desirudin. You read their name, all their name end with Rudin, Rudin, Rudin. So this Desirudin is also used during hip surgery. So should we do lab monitoring for all these things? Yes. So when you are using these drugs, you have to do the monitoring, that is both APTT, right? So mainly you have to do APTT for this. But what about the drug which binds to catalytic site of 2A? The name is called argatroban. So we read the name thrombin. So the mechanism is thrombin. So TROB stands for thrombin. AN stands for antagonist. So it's a thrombin antagonist. The name is argatroban. So when you are using argatroban, you have to monitor both APTT as well as PT. So they require lab monitoring. Very, very important. And remember, these drugs are injectable drugs. Then what is the oral drug which we have? The oral drug, they are called oral direct thrombin inhibitor. The name is called dabigatran. The name is dabigatran. Dabigatran is an oral drug, so we call it by the name Novak. So what do you mean by Novak? Novak stands for novel oral anticoagulants. Now what is novel? Novel means new. This is a new oral drug. Do we have any older oral drug? Yes, warfarin was the older, but we have a new one. That's why it is called novel. They're also called as DOACs. DOAC stands for direct acting oral anticoagulant. So dabigatran comes under NOACs as well as DOACs. So where do I use this drug? Dabigatran is used for venous thromboembolism prophylaxis, VT prophylaxis. It is used in hip surgery to prevent the thrombus formation, and it is also used during atrial fibrillation. The name is dabigatran. Now, do we have any antidote for this? Yes, we have a monoclonal antibody. It starts with IDA. So I for inhibitor, DA for dabigatran. It is called idarucizumab. The name is called idarucizumab. So I for inhibitor, D for dabigatran. The name is called idarucizumab. Sir, when you use dabigatran, should we do lab monitoring? Please remember, this drug doesn't require no lab monitoring. No lab monitoring, not required. But when we use warfarin, we require that. That is the reason these are the drugs which we prefer nowadays in comparison to warfarin. But still today, the best drug for prosthetic heart valve or mechanical heart valve is warfarin. Don't use, these are not used in a patient with prosthetic heart valves. They are not shown to be effective in these patients, so don't use them. And if you are using and waiting, there is a chance of clot formation and the patient may have stroke. So it is not used in prosthetic heart valve patient, that is dabigatran. So we have only oral direct thrombin inhibitor, that is called dabigatran. So it has an antidote called idarucizumab. No lab monitoring is required. It's an oral drug. It is come under NOAC or DOAC. Going on to the fourth target. The fourth target is called direct 10A inhibitors. They are called as direct 10A inhibitors. And the name is like this, apixaban. So the name is ending like this, XA for 10A, ban, it will stop that. Ban the 10A factor. You take the example of one more, betrixaban. Then if you take edoxaban, then rivaroxaban. So everywhere it is XA-band drugs. So you can identify this. And please remember, this is also Novak. This is also Dovac. So it's a novel oral anticoagulant, directly acting oral anticoagulant. Remember, these drugs are used for venous thromboembolism prophylaxis, hip surgery prophylaxis, and they are also used in atrial fibrillation. But these are contraindicated in prosthetic heart valve. Prosthetic heart valve. Now, once we understand this, is there any antidote if there is overdose of these drugs? Yes. Now you write like this. You know this is the drugs are 10A inhibitors, right? XA, NET, alpha. So the drugs are, antidote name is hexanet. It is called as and hexanet alpha. So that is the antidote for this direct 10A inhibitors. What about lab monitoring? Should we do lab monitoring? No, not required. No need of lab monitoring for this. So they are called direct inhibitors. They are NOACs. So NOACs, if they ask in the exam, we have dabigatran and XA-band drugs. Please keep that in your mind. Very, very important. Now I will summarize certain things for you. Now whenever we discuss anticoagulants, so you should be knowing which one is injection and which one is oral. So the injections are the unfractioned heparin, the low molecular weight heparins. Then we have, yes, one more drug, fondaparinux, and the parenteral direct thrombin inhibitor. The oral drug, the old one is the warfarin group of drug, and the NOACs, that is novel, new one. There are two types, the 10A inhibitor, they end with XA-ban, and the drug by the name dabigatran. Now what I will do is, I will also give one more summarization here. What drug is having an antidote? So unfractioned heparin and low molecular weight heparin, they have an antidote, and that is called protamine sulfate. PS means protamine sulfate. Fondaparinux doesn't have an antidote. Parenteral direct thrombin inhibitor, they don't have an antidote. Warfarin has an antidote. Yes, take a guess. Vitamin K. And dabigatran has an antidote. It is called idarucizumab. So it is called as idarucizumab. 10A inhibitors have an antidote, and that is called and hexanet alpha. Yes. Now I will do a list of drugs which require lab monitoring. So which group of drug require lab monitoring? Which group of drugs require lab monitoring? For unfractioned heparin, you have to do mainly APTT more than PT. Warfarin requires lab monitoring, and that is called INR, International Normalized Ratio. Low molecular weight doesn't require, fondaparinux doesn't require. Then if you are using parenteral direct thrombin inhibitors, they require the lab monitoring, that is APTT, as well as PT if it is argatropan. Apart from that, no other drug usually require lab monitoring. So this is what we need to discuss. So that's a summary of where we use it. So in the conclusion, let me conclude this anticoagulants. Even though I went in extensive way, Please understand basically the mechanism of action. Heparin, unfractionated heparin, fondaparinux, they activate antithrombin 3. They are not directly acting. By doing that, they are indirectly acting and they block the clotting factors. Unfractionated heparin, both 2A and 10A. Low molecular weight heparin, 10A more than 2A. Fondaparinux, only 10A. Antidote is only for unfractionated heparin and low molecular weight heparin. Low molecular heparin, protamine sulfate, is called incomplete antidote. And what requires lab monitoring is unfractionated heparin. Coming to oral drug warfarin, it is a vitamin K antagonist. It inhibits the enzyme vitamin K epoxy reductase competitively. And it's an oral drug, it takes time. Adverse effects are more important: bleeding, teratogenic, and it can cause skin necrosis. How do you prevent that? By heparin bridging. Recent drugs are direct from inhibitors. We have parenteral and oral, and they end with rudin or a drug called argatropan. The oral drug is called dabigatran. Then we have the oral 10A inhibitors. They are called XA band drugs. And the antidote for XA band drugs are andexanet alpha. Dabigatran, it is called idarucizumab. Okay, so that is about anticoagulants. Thank you all.